This conference will now be recorded.
Okay, welcome all to the class. So today the class is about the vulval cancer because there has been update about the staging. Also, there had been update in this BGCS guideline also. So I'll try to cover both of them along with the question discussion. Okay, if any one of you found any question in between, you can just stop me and I'll explain. Let's start together. So vulval cancer, it is one of the rarest malignancy in gynecology. In UK, vulval cancer is accounts less than 1%. Okay, it is less than 1%. And vulval cancer is more common in older postmenopausal women with a peak incidence is 90 plus years. Now, histopathological classification, there are two types. One is squamous. So 90% of the cancers are squamous cell carcinomas, and this is important question also. Rest 10% they are non-squamous um, uh, carcinomas. These are like malignant melanoma, basal cell carcinoma, Bartholin gland tumor, or adenocarcinoma, varicose carcinoma, and sarcoma. Okay, so this is the classification of squamous and non-squamous carcinomas. Now, coming to the pathology, what is the precursor lesion and what is the pathological type? You may get question from there, and it is important to understand the basic lesion or precursor lesion behind, because sometimes your treatment depend on that also. Now, vulval squamous cell carcinoma, like there could be two pathology, two type of pathway. One is like usual UVN and another is DVIN. Okay, so UVIN is HPV related. I'll be just explaining that. Another one, second one is DVIN, that is vulvar dermatosis related. So there are two pathways for squamous cell carcinoma. Now, for Bartholin glands carcinoma, it is HPV related. Most of the time, it is UVN or usual VIN HPV related. Okay, this is a precursor lesion or baseline lesion. For melanoma, it is vulval acanthosis with altered differentiation. For Paget's disease, it is the vulval Paget's disease. Okay, so these are the precursor lesions and this is the pathological subtypes. You may get question from there. Now, the important part from where the understanding and the required in the questions comes. So as I said, there are two type of pathway. One is like DVN. This is the DVN, and another one is UVN. So first pathway that is common, that is a differentiated DVN is differentiated VIN. Okay, it usually occur in the background of dermatosis, like lichen sclerosis or lichen planus. Okay, most likely lichen sclerosis. And in this, if the DVN is there, then chances of progress to cancer is about 30%. Okay, this is DVN pathway or dermatosis pathway. And the second pathway is UVN, that is related to HPV. Baseline is HPV. There would be HPV infection that will further progress, and it counts for 25 to 30% of vulval cancer. Apart from this, HPV infection, we already know it causes HSIL, that is the high grade squamous intraepithelial lesion, or usual VIN. So this is UVIN pathway. And usually, if the treatment progression to cancer would be 9 to 16%, this percentage is important for you. And like if the treatment is done, because if we see the patient of VIN, usually we do excision and then we treat them. Now, another question may come, if the treatment is already done, then how much is the progression to the cancer could be there? So it is 3%. Okay, so untreated patient cancer can happen in 9 to 16%. In treated, it can happen 3%. Apart from this, smoking, HIV, infection, and immunosuppression, they are predisposing factor that we already know. Okay. And Paget's disease, though it's a rare condition, and vulval adenocarcinoma may present in 4 to 8% of women with a Paget's disease or vulva. Okay. So these are kind of risk factors. Now, UVN or HPV related pathology. So there would be baseline HPV infection that will cause usual VIN, and that would lead to warty or basiloid vulval squamous cell carcinoma. Okay, so this is important, okay, to know. And this is the picture, pathology, microscopic picture of VIN3, but not important. Now, we know HPV causes multiple lesions, so it would be multifocal. There could be many lesions. It could be multicentric, like maybe associated pathology. Maybe they are in anus, or maybe they are in cervix. Apart from this, HPV infection occurs in younger people, so it usually happens in premenopausal women. Okay, again, it is related with HPV, smoking, and immunodeficient conditions. And if we call as a if there could be any prevention, yes, giving HPV vaccine is a prevention, because then the high risk, or the HPV infection will not be there. So all this progression and this pathway can be blocked there. So prevention is HPV. What is the treatment for VIN? I'll be just speaking. Okay, so this is um, HPV related UVN. Same again. So now, if we see the histopathology, so what could be there? So there would be cytological atypia. There could be mitosis more than middle third of epithelium, immature squamous cell with or without HPV stigmata, that is the choliocytosis. So basically, this is from the BGCS guideline only. So HPV related lesion, you will find a choliocytosis. Okay, so this is kind of, so there are certain changes in the cell, and that is related to HPV, and these are the choliocytes. So this you should know because it comes in question. Again, as I already told, it is multifocal disease, so it is very important. There should be, we need to know any associated lesion. So colposcopy to be done, and vulvoscopy to be done, and inspection, and if any associated lesion like anal lesion is there, that also has to be done. So if we have to see, like consider seeing other areas also. It is many of the time HPV infection is associated with HIV, so HIV testing to be done. Okay, so if HPV related pathology is suspected, colposcopy of cervix, vagina to be considered to exclude other pre-malignant lesion, and HIV testing should be considered. Okay, so this is the picture, screenshot from the BGCS guideline that almost says the same thing. Multifocal HPV related lesion, there should be colposcopy of lower genital tract, there should be digital anorectal examination, and because there could be possibility, you are seeing at a advanced condition when the cancer is already there. Multifocal disease, do HIV testing, and inspection, vulvoscopy, so everything has to be done. So it is a multifocal, so you have to kind of rule out involvement of other areas. Apart from this, you have to also do HIV testing. So this part is important to understand, then the answering questions become very easy. Okay, so now this was what till now I have discussed. This was VIN, that is usual VIN. So the second pathway for the cancer is the DVIN. This DVIN is differentiated VIN. So what is a baseline lesion? It is usually lichen sclerosis. Lichen sclerosis lead to differentiated or DVIN, and it causes keratinizing type of uh, this like vulval squamous cell carcinoma. Okay, so usually, as it is, we are saying defined lesion. So usually they would be unifocal or unicentric. So usually one or two lesions are there. Okay, it is defined, completely defined condition. Okay, and in the if this is the etiology, usually it occurs in postmenopausal women associated with lichen sclerosis. There is a non-viral pathology. It is not associated with any cervical involvement or anal involvement. Okay, so this is a different pathway, and possibility of developing squamous cell carcinoma is high. So these are the different between deviant lesions and uvein lesions. Now, if we see why it happens, it is associated with p53 mutations. Okay, associated with p53 mutations. If the good control of lichen planus and lichen sclerosis, we know the treatment is ultra potent steroids. Okay, if the treatment is done, then there would be decreased incidence of squamous cell carcinoma with DVIN pathway, but currently there is no screening test for vulval cancer. Apart from this, usually when these conditions like dermatosis, vulval dermatosis, lichen sclerosis, and lichen planus, the follow-up is if they are uncomplicated, then the follow-up is done in the primary care, and if everything is fine, like disease under control, then yearly follow-up is done. But if they have got any new lesions, then secondary care they would be referred by the cancer weight pathway. If there is possibility of cancer, if the patient is not improving with the ultra potent steroids that usually we give the offer them the ultra potent clobetasone steroid. Okay, so this is from the your BGCS guideline. So this is different pathway of developing vulval squamous cell carcinoma. This is DVN. So is it clear, people, about the pathway for UVIN and DVIN? Any question till now?
Clear, ma'am.
Okay. Now, what could be the common sign and symptoms of VIN? Okay, so usually the pruritus, and there could be they may cause dyspareunia. Lesions may be raised, erythematous, leukoplakic, keratotic, ulcerated, pigmented in appearance. Okay, many of the time, I have seen a EMQ also where the keyword was pigmented, so then it was VIN. Okay, and they, because when these lesions are there, if we do colposcopy on application of acetic acid, they appear aceto-white. And approximately 50% of the cases of VIN, they are asymptomatic. Okay, and as we know, the VIN associated with CIN and like anal intraepithelial neoplasia, so they also has to be examined. Usually you have to do them if you are suspecting HPV related lesion. Okay, so this is the presentation of the VIN. Now, options for treatment for VIN, it could be wide local excision, it could be skinning vulvectomy, it would be laser ablation, and medical therapy 5-fluorouracil and imiquimod in 5%, or photodynamic therapy. So with imiquimod, cidovir, and surgical excision for high-grade VIN, and 50% response rate by 12 months of post-treatment. But cidovir is not licensed in UK at this stage for VIN treatment. So that's all about the VIN. Okay. Now coming to vulval carcinoma. So vulval carcinoma, now how the patient will present. So the most common symptom with the patient will present will be pruritus. Okay, so patient will come with the pruritus. There could be from the bleeding associated, there could be some lump, there could be ulceration, burning, pain, discharge, or asymptomatic, sometimes asymptomatic up to 5% of the cases. Typical appearance of the vulval cancer lesion will be raised ulcer with rolled margins. Okay, so this is the sort of a raised ulcer with rolled out or rolled out margins would be there. Okay, so this kind of lesions, this is a typical appearance. Apart from this, when you do your questions, then also this will be sort of a keyword that will help you in find that you are dealing with the like malignant lesion. Now, what are the prognostic factors, that affect the survival? It will be the inguinofemoral lymph node metastasis, FIGO stage, histopathology, grade of the tumor, depth of invasion, age, and performance status of the patient. But the metastatic disease in where most important factor would be like metastatic disease in regional, that is the inguinofemoral lymph node. Okay, so if it is like you can just see also, if the nodes are not there, then the survival is uh, like 92%. But as it got as it nodes are increasing in the in metastatic disease, then it is also affecting the survival also. Now another thing, though it is not necessary to remember, now also when they do like lymph node, when they see on the microscope, then they calculate the depth of invasion. If the invasion is like in 1 and 2, and then incidence of positive node will be 8. But if the invasion is high, 3 to 5, then the positive node will be 30%. This is from the strategy, but this number is not that important. Basic idea to know that the metastatic disease in guernofemoral lymph node is the fact important factor that determines survival, and accompanied with it would be the depth of invasion. Okay, apart from this, now the patient has come and you have examined the patient. Now what how you will confirm, then it has to be done is the biopsy. So examination and biopsy prior to any kind of treatment, because we have to know confirm the diagnosis. It can be carried out in the clinic under local anesthetic. Now this is the very important part. So incisional biopsy, what type of biopsy to be done, for the diagnosis, it would be incisional biopsy. And that is it may called it may be a punch or it may be a wedge. So what is the incisional biopsy, that you will find question from there, and it is important to understand also. So incisional biopsy would include edge of the lesion where there is transition from normal to abnormal tissue. Okay, so like we are taking a little part of normal and abnormal tissue. So from that edge of the lesion, usually the biopsy is taken. From the center of lesion, it should not be taken because it will not be diagnostic. Apart from this, biopsy has to be adequate depth, because we want to know whether it is a superficially invasive or a depth of invasion, or it is a more invasive, deeply invasive, like if it is more than 1 mm or not. So because the treatment usually depend on the depth of invasion also. So when the biopsy is done, it should be adequate depth, so that we are able to find out whether invasion is less than 1 mm or more than 1 mm. So this part is very very important to understand, because many of the question will be there from this line only. Now another part, in the some of the questions you will find excisional biopsy, what the guideline says, and strategy also, that the excision biopsy should not be done. Why? Because if we have excited the whole lesion, then more conservative treatment in form of wild local excision and sentinel node biopsy, that option will be gone then, and it will affect further treatment and the staging also. So excision biopsy should be avoided completely. But there are certain uh, ex- uh, exception to this condition. Like if there is a very old woman, that a small lesion is there, and like she can't go for too much of treatment, then in that condition, consideration for excisional biopsy for palliation purpose can be done, but it has to be done by the gynae oncologist, because they will be performing, subsequently her treatment also. So that message from here, that whenever you are suspecting there could be vulval malignancy, you have to completely examine the patient clinically, and apart from this, for the confirmation of diagnosis, there has to be a biopsy, and biopsy should be incisional, from the edge of the lesion, where the transition from normal to abnormal tissue is there. Important part, it should be adequate depth, so that like how much the invasion is there, that we will be able to find out. Okay, so that's all this is all about the biopsy. Now this is the BGCS recommendation for biopsy. Now, what they say that there should be clear documentation about or clinical examination of the size of the lesion, distance from midline, clitoris, anus, vagina, urethra, and they should be imaging with the indication of biopsy site, and clinical drawing. So like ideally there should be a drawing indicating what are the lesions and from which sites the biopsy is taken. Again, suspicious lesion to be sampled with a punch wedge biopsy. Excisional biopsies are avoided. Same thing I have told you. It should be from the edge of the lesion. That also I have told you. And this also, there should be a diagram, and clinical photos can be taken. And if the biopsies are taken from, if it is taken from the one side, it can be sent in a one pot. But if it is from separate sides, then different spots and the labeling has to be done. All cases of vulval cancer uh, di- uh, should have diagnosis confirmed by special MDT before the treatment, before any treatment is done. Okay, so many of the your part 2 or part 3 question, you have to involve this, and this is very important, that treatment can't be done without any special available MDT. So that these are the all about biopsy. So any question till now? Anyone of you have got any question?
No, ma'am.
Okay, so now for the treatment planning, what they want, to be document: size of lesion, location, appearance of background skin, whether there is involvement of vagina, urethra, bladder, and anus, infiltration of pubic or ischial bone, whether there is a presence or absence of enlarged groin lymph nodes. Okay, so this would be the clinical documentation. Apart from this, preoperative imaging to CT or MRI to rule out the lymph node associated, or if any distance metastasis. Chest imaging to be done, either X-ray or CT. PET-CT is done when we are thinking that there could be already is advanced disease, and we are thinking of radical chemoradiation, that because as a primary treatment modality, that means advanced disease. That time PET-CT to find out complete metastasis condition would be done. All cases, same thing again, all cases to be reviewed by specialist multidisciplinary team prior to any definitive treatment. Now, this is BGCS recommendations for preoperative investigations. Okay, so what they say, they should be uh, for gross nodal involvement to be excluded by clinical examination, whether clinical any node is there or not. Apart from this, imaging, and as the sentinel lymph node biopsy is considered, so before that, considering that, imaging to be done to find out whether on the imaging they can find out enlarged lymph node or not. So it could be by USG, CT, or MRI. Now like PET-CT, if metastatic disease, same thing I have told. So if it is an advanced disease or metastatic disease, that time consideration for PET-CT can be done. So that treatment would be radical. Okay, and additional imaging for basal cell carcinoma lesion is too much, it is not done. Melanoma and Bartholin cancer, uh, imaging to be done to find out local disease and metastatic disease. Okay, so these are the recommendation by BGCS for pre-op investigation. Basically, after clinical examination, there would be biopsy for the confirmation. Before go for the treatment, they had to do the investigation, because they have to find, we need to find out whether the lymph nodes are involved or not. Okay, so this is the BGCS recommendations for pre-op investigations. Now this is very important, and that would help in the treatment also. Now, if the patient comes with the like symptoms of pain, bleeding, irritation, now they have created the pathways. Now, on looking at the lesion, if it is like low suspicion of malignancy, clinically benign condition, then patient can be discharged to the primary care to be taken care in the community. Now, if clinically looking at the condition, uh, if it appears like VIN, then there would be biopsy, and like uh, along with the from the lesional, starting from the lesional margin with the photos and diagrams, excisional biopsy will not be done. Okay, so this is the VIN. Now, if clinically it appears, either it could be lichen sclerosis or lichen planus, then the treatment with the ultra potent steroids are done. If the patient has no improvement, then they have to go for the biopsy. When the high suspicion of malignancy is there, now then there is no treatment. You have confirmation of diagnosis by veg biopsy, and then referral to the gynae oncology team is done. So this is the pathway when the patient comes with a suspicion lesion in the vulva. Is that clear?
Yes, ma'am.
Okay, now coming to the staging. So this is the FIGO staging 2021. So now the stage one. So stage one, previous staging was in 2009. Now new staging has come in 2021. So usually in this staging there is no change, only there is a change in the method for measuring depth of invasion. So this is the change. Okay, this is the change. So depth of invasion is measured from basement membrane of deepest dysplastic tumor free uh, rete ridge to the deepest point of invasion. Okay, previously they were measuring from epithelial stromal junction uh, to the deepest point of invasion. This the Only the way they check for invasion, only this much has changed in stage one. Rather, stage one is same. So stage one, tumor confined to vulva. Stage 1A, tumor less than less than equal to 2 centimeter, and stromal invasion less than equal to 1 mm. Tumor 1B, size is more than 2 centimeter, and stromal invasion more than 1 mm. So this FIGO stage for stage 1 is change. There is is same. There is no change. Okay. Now stage 2 also there is no change. It is tumor like carcinoma. Now it extends from the vulva to the adjacent structures. So adjacent structures are involved, but there is no change. No nodes are involved. So it is a tumor of any size, but involving lower part of urethra, vagina, anus, UVA. Lower one third of UVA is involved, but nodes are negative. Okay. So again, stage 2, previous and current stage, there is no change. Now the changes are there here. And this is the stage 3. In stage 3, it is carcinoma that just extend to the nearby perineal structures. Apart from this, there any non-fixed and non-ulcerated lymph node. So lymph nodes are there, but they are non-fixed and non-ulcerated. Okay, so now here the changes are there. So 3A, tumor of any size with extension of upper perineal structure with any number of non-fixed, non-ulcerated lymph node. Now, or a tumor of any size involving upper two-third of urethra, upper two-third of vagina and bladder mucosa, rectal mucosa, and regional lymph node. Now here it is invasion less than equal to 5 in mm. Okay, so here it is changed. Previously, upper two-third involvement of UVA, that is urethra, bladder, and vagina. It was stage 4A. Previously, this upper two-third was in stage 4A. Now there is a change. Now they have put upper two-third of UV, urethra, vagina, and rectum or anus in in 3A. So there is a change. So here there is a change. Okay, previously they used to say one lymph node or one and two lymph node. Now it has been changed, so a little, in my opinion, it has become a little easy, because need not to remember any number of lymph node. Now only regional lymph nodes metastasis less than equal to 5 mm. Okay, so this is 3A and there is a change there. Now 3B, it has again become easy. 3B will be involvement of lymph node more than 5 mm, more than 5 mm, and 3C is the same. Here there is a involvement of lymph node with the extra capsular spread, with the extra capsular spread. Okay, so 3C there is no change. 3C there is no change. So this is the till now the change has occurred in stage third only. Is it clear what are the changes, people?
Yes, ma'am.
Okay, stage 4. Stage 4, uh, now it has become easy only. So stage 4, when the disease is fixed uh, to the pelvic bone, so fixed or ulcerated lymph nodes, and 4B will be any distance metastasis. Okay, so any distance metastasis. So here again the change in 4A that I have already explained. So in my opinion, if I see as a whole, the stage little has become easy. Let me go again. So stage 1, tumor confined to vulva, 1A, less than 2 centimeter, less than equal to 2 centimeter, and stromal invasion less than equal to 1, and 1B will be more than 2 centimeter tumor size and the stromal invasion more than 1 mm. Now stage 2, it will be involvement of lower urethra, vagina, and anus, UVA, no nodes. Stage 3, 3A will be involvement of upper urethra, vagina, and rectum, and regional lymph node less than equal to 5 mm. Third B is more than 5 mm, and 3C would be extra capsular spread. 4B, 4 stage A is all fixed, that is fixed, disease fixed to pelvic bone, or ulcerated or fixed lymph nodes. And 4B is usual for everything, that is any distance metastasis. So this is small change in the staging is there. Now this BGCS now have put this diagram. So though it is almost the same that we used to do previous with the previous guideline, But yes, now if they have done like that, I'll be explaining it to you. So management of primary lesion. So now if biopsy proven lesion is there, now in the biopsy we just discussed, they want us to comment on depth of invasion. If it is less than 1 mm, less than 1 mm, so that means it is stage 1A. Okay, so what they want as a treatment: wide local excision with photo and diagram indicating the biopsy site. Now because in your exam, if they give you two options, one is wide local excision, another option is wide local excision with photo diagram indicating biopsy site, then that would be the answer. And here there is no sentinel lymph node biopsy is required because depth of invasion is less than 1 mm. Okay, same here you can see in the diagram. So depth of invasion less than 1, so the treatment would be wide local excision with a photo diagram, and lymph node biopsy, a sentinel lymph node biopsy not required. Okay, so this is treatment with a depth of invasion less than 1 mm. Second part of it, if the depth of invasion is more than 1 mm, okay, so it would be like 1B and more. So after that, now they have to consider doing lymph node imaging. Uh, that could be done with a CT, and with the lymph node imaging they will do. And now on the treatment will be like this: if we see that on the imaging there are no nodes, and also the lesion is less than 4 centimeter, then they will do like wide local excision will be done. But for the lymph node, it would be if the lateral lesions are there, then unilateral um, sentinel lymph node biopsy. And if it is um, central lesions are there, then the sentinel lymph node biopsy of both side has to be done. Now let me explain you what is the midline or central uh, tumors and what are the lateral tumors. So the tumor that lies in the within 1 centi, if we within 1 centimeter of midline, then these are called as a central tumors, and that would usually involve clitoris, urethra, and anus. That is the central part of the vulva within 1 centimeter. So any lesion, if it occurs in the center, then usually uh, there is a lymph node, there is a cross section of the lymphatic channel. Okay, so lymph node, whatever the treatment you do, it has to be on the both side. And lateral lesion, when they are more than 1 centimeter from the midline, so these lesions will be lateral lesions. And for the lateral lesions, only that side lymph node treatment would be required. Is it clear what are the central lesions and what are the lateral lesions?
Yes, ma'am.
Okay, now uh, so this is if the sentinel lymph node biopsy, if the lesions are less than 4 centimeter and no nodes. But if you see on the if the nodes come positive on imaging, or if multiple lesions are there apart from this, if the lesion is more than 4 centimeter, in that situation lymph node dissection has to be done. For the lateral lesion, it will be same side or ipsilateral, and if it is it will be bilateral lymph node in dissection. If the lesion lies in the center, that we that is within the 1 centimeter of midline. Second condition where we have to do the bilateral lymph node dissection, if one side lymph node comes positive. If ipsilateral or same side lymph node come positive, then we have to consider removing other side or contralateral also. Okay, so it is the previous guideline also it was same, but now they have made it more systematic. Now I have explained you this part of the diagram. If the depth of invasion is more than 1 mm, then they would do imaging to find out lymph node, that is CT scan. If it is no nodes less than 4 centimeter, then they will do sentinel node biopsy, unilateral for lateral lesion and bilateral for central lesion. If the primary lesion more than 4 cm, multifocal disease, and lymph nodes are there on scan, then they will do ipsilateral lymph node dissection for lateral lesion, or like bilateral for the central, or bilateral if the ipsilateral one side lymph node is involved. Okay, so this is the basic management that this new guideline explains. Is it clear?
Yes,
Yes.
ma'am.
Okay. Now, what is the like recommendations from BGCS? So, what they say excision. So, excision will be like excision should be planned that at least 1 centimeter in situ with the goal of achieving clear margin on pathology. And they, whenever the excision is done, uh, they should allow preservation of clitoris, urethra, and anus. That is a central lesions. So it is they want excision with the 1 centimeter. Okay. So now if the excision is done and the histopathology comes back and they find margin positive, so what will be the treatment? So in that situation, re-excision is a treatment of choice. Re-excision is a treatment of choice, and whatever the treatment you are doing, it would be under like a multidisciplinary team approach. And sometimes if the like larger lesions are there and removal is more, then sometimes they may require reconstruction also. Apart what they have said for the lymph node, same thing again. Now if it is more than 4 centimeter or multicentral disease, then in that situation they will remove lymph node of both side, and there would be separate incision. Okay, there will be separate incision for the lymph node. Apart from this, if they are considering sentinel lymph node dissection, that is same thing I have already explained. Lesion less than 4 centimeter, unifocal lesion, no nodes, and it is lateral condition. That means central part, urethra, vagina, anus is not involved. So then they will consider lymph node, sentinel lymph node dissection. Here the message is that they will do separate incision for lymph nodes. Okay. One more important thing, when they remove lymph nodes, inguinal femoral lymph nodes, so there are two groups of lymph nodes are there: superficial lymph nodes and deep lymph nodes. So in the lymph node they would be removing both superficial and deep. Apart from this, deep usually lies near the saphenous vein. So preservation of saphenous vein is very important because it will be reducing post-operative complication. Okay, so it is very important. Apart from this, if the advanced disease is there, then there will be multimodal treatment is done, and with the involvement of MTT. If it is a bulky disease, that means that lymph node is more than 2 centimeter, then there would be removal will be considered. Why? Because to treat it with the radiotherapy would be difficult. To treat it with the radiotherapy would be difficult. So this is what the guideline says about the management of inguinal lymph nodes. Okay, a little complicated they have made, but the message is same only. Now, sentinel lymph node dissection, where the sentinel lymph node dissection is done. Like when the unifocal disease, depth of invasion less than 1 centimeter, tumor less than 4 centimeter, when perilesional injection is possible, because they give injection and then the dye will go to the lymph nodes and they see what is the first lymph node involved. It should not be the central lesion. There should not be any lymph node. So these are the criteria for sentinel lymph node dissection. Now, sentinel lymph node dissection. So, in, they these days they also can do pre-operative this test can be done, so that they are able pre-operative test, so they helps to identify location and number of sentinel lymph nodes. Apart from this, usually they use some dye, or they use some radioactive elements. They push it, and then they have got a hand tracer. With this, they are able to find out whether sentinel lymph node is the first lymph node that is drained from that area. So with the hand tracer, they're able to find out whether the lymph node is involved or not. So this way, usually the sentinel lymph node, dissection, they are able to identify. Now this is again the same thing. If they find now if they are doing a sentinel lymph node biopsy, and they're sorry, if they are checking for the sentinel lymph node and they found it positive, then they will do the inguinal lymphadenectomy for the groin. Okay. And if the midline tumor is there, then both side they will check it, and if one side lymph node comes positive, then lymphadenectomy for the other side also to be done. Apart from this, now they if the a sentinel lymph node dissection was planned, but because of the but they are unable to do so, or if there are some issues, they consider that is a method failure. That if they are not able to find the sentinel lymph node, so they will consider inguinal lymphadenectomy. Because if we are unable to know whether the first lymph node is involved or not, in that situation they will consider a lymphadenectomy. Okay. So that's all about the sentinel lymph node dissection, or that the guideline says. Okay. Now this also, they have made a little more tricky thing, but the message is again same. So what they say for the stage A disease, so the treatment would be by excision. Usually their aim would be that the margin around the all primary tumor should be removed. 1B, it is again a radical wide local excision. Apart from this, if it is a large or multifocal tumors are there, in that situation consideration for radical vulvectomy can be done. Okay. Stage 2, the again it is a surgical removal, but if the anus is involved, then they may consider giving new adjuvant chemoradiation to shrink the tumor. Otherwise, if the surgery is done, it may further involve the sphincter. Okay. And stage 3, it is same as the earlier stages, whatever the way we have explained the excision and the lymph node, it is the same kind. And if they are removing the lesion and by one incision, and they are giving two separate incision for the lymph node, then there would be a skin bridge in between. So what they say, recurrence in skin bridge between positive lymph node when tumor is low. Stage 4 disease, like very locally advanced disease, all fixed, and all distance metastasis is there. So surgery has a very limited role, because what to remove. So in that situation, consideration for palliative measures can be done. Palliative measures can be done. Like if the sphincters are involved, they may consider doing defunctioning stomas, urinary diversions, even the nephrostomies also. So the palliative treatment is done. Now, though the surgery is the commonly treatment of choice for the vulval cancer, and how to decide which kind of surgery to be done, I have already explained. But sometimes the patient seems inoperable, because it is too advanced disease, or if the surgery is done, then patient will become incontinent, or because the damage to sphincter would be there. Apart from this, the patient doesn't want any diversion or stomas. In that situation, consideration for primary radiotherapy as a treatment can be done. Now, once the surgical treatment is done, then usually the specimen would be sent for the histopathology. Then, depend on the histopathology, the decision will be done whether the adjuvant therapy is required or not. So this is important to know, because you will get question from there, and there is a change also. So if the margins are of tumor is positive, consideration for adjuvant therapy. If more than one metastatic lymph node, in previous guideline it was more than two metastatic lymph node. Okay, so there is a change now with like more than one metastatic lymph node, like more than one metastatic lymph node, more than one metastatic lymph node, they are doing adjuvant therapy. If extra a second, if there is a extra capsular lymph node spread is there, or if the pathological margin is less than 2 mm, pathological margins of the like the specimen removed is less than 2 mm, uh, then in or re-excision ideally to be done, it is not done, then they will consider for the uh, adjuvant post-operative radiotherapy. So these are the this few things that you should know. Usually you will find the question from the lymph node only. Now recurrent disease, rate of recurrence for squamous cell carcinoma, it varies from 15% to 33%. So recurrence is there. Apart from the most common site for the recurrence will be vulva only. It recurs in the vulva. Okay. And for the recurrent disease, what could be the options? Consideration for surgery, consideration for radical radiotherapy, neoadjuvant chemotherapy, palliative radiochemotherapy, consideration for even new approaches, immunotherapy, and supportive care. Okay, this is for the recurrent disease they have to do. Now, sometimes there could be local node recurrence only. Only nodes are getting recurrences happens in the nodes only. That time, first they will do CT and PET CT, because they have to find out how much the recurrence is there. Then if the only groin relapse or like nodes of the groin relapse is there, consideration for re-excision can be done. But if surgery is not possible, then palliative radiochemotherapy or combination of both to be done. So this is all about if there has been local node recurrence. Now follow up what the guideline says, like proven regimen for follow up of squamous cell carcinoma is not there. So what they say, if the UVN pathway like HPV related pathway, vulval cell carcinoma, if there is no recurrence, then they can be discharged with the access to the rapid re-referral after 5 years. Okay, because they have got they occur in a young patient and prognosis is good. For recurrent disease, multifocal disease, there could be possibility of lifelong follow-up. Okay, so now that's all about the squamous cell carcinoma. Now, any question till there? Okay, now non-squamous carcinoma, sometime question comes from here also. So these are Bartholin gland carcinoma, uh, adenocarcinoma arising from non-memory Paget's disease, basal cell carcinoma, and malignant melanoma. Okay, so only I'll be speaking very less about that, because you need to know about it also. So carcinoma of Bartholin gland, it out of vulval malignancies, non-squamous, it occurs in 5%. Bartholin gland is a deep-seated gland, so the lesions are deep-seated. Resection, if it is done, it may compromise anal sphincter. Therefore, partial resection with reconstruction with a temporary defunctioning colostomy may be required. Apart from this, if the patient has a Bartholin abscess again and again, there it is persistent, and or persistent abscess or cyst is there, then they should have a biopsy, because sometimes there could be underlying carcinoma of Bartholin gland. So it is very important. Now, what the guideline says, that it develops deep in the vulva, so the surgical management would involve extensive dissection. potentially the anal sphincter may be involved, may require plastic reconstruction. In Bartholin gland carcinoma, there is no evidence or data for sentinel lymph node. So, because of that, it is a central lesion also. Okay, so bilateral inguinofemoral lymphadenectomy is recommended. Okay, both side lymph node to be removed because it is a central lesion also. Now, when they come to the to see the hospital, they are already advanced stage, 3 or 4, and like and so they have to be like metastasis. Look for the metastasis already. And for Bartholin gland carcinoma, they need multimodal treatment. So CT cap is required prior to surgery. What is cap? Is the CT scan of chest, abdomen, and pelvis, because they are coming at very advanced or metastatic stage. So a CT cap, that is the chest, abdomen, and pelvis, is required before they go for surgery. Now, basal cell carcinoma and verrucous cell carcinoma, usually they are treated, both of them are treated by the wide local excision only. And in this, lymphadenectomy is not done. So, basal cell carcinoma and verrucous carcinoma treated by wild local excision. And in verrucous carcinoma, anaplastic transformation has been reported with the radiotherapy. So radiotherapy is contraindicated. So this you should know that it can come in a question. But radiotherapy can be used for basal cell carcinoma if like surgery is going to compromise the function or something like that. So for basal cell carcinoma, initial follow-up will be for 3 months for healing and local recurrence. Too much long follow-up is not required if the complete excision is there. Now, malignant melanoma. So, malignant melanoma is the second most common vulval malignancy after squamous cell carcinoma. Second most common malignancy. Relapse rate is very, very high, and their depth of invasion uh, related with the Breslow's thickness. Now, what the treatment is, what they say, the discussion to be there is like melanoma MDT is there. So the treatment to be done with in the collaboration with gynae oncology and the melanoma MDT. Okay, and what they want as a treatment option, it would be aim to surgical aim will be to excise it. A surgical aim will be to excise it. Sentinel uh, node dissection helps to guide, usually not done, but it helps in guidance of adjuvant immunotherapy. It helps in guidance of adjuvant immunotherapy. Metastatic lymph node disease may be considered for removal as may improve the quality of life, but evidence for survival benefit is not there. So usually in melanoma, uh, lymph node dissection is usually not done. So sentinel lymph node dissection to find out whether the immunotherapy will be helpful or not, adjuvant immunotherapy. Apart from this, what they say that if the metastasis is also there, then it may be considered for removal, but without evidence of survival benefit. But survival benefit evidence is not there. If we look at the previous guideline, so in melanoma and basal cell carcinoma and verrucous carcinoma, previous guideline says no to lymph node dissection or lymphadenectomy. Okay. So apart from this melanoma required very, very long-term follow-up. Now, no need to know so much about it. It was there, so I put it. So it will be 3 monthly, then 6 monthly. Then, basically, I want to say that like uh, they are doing follow-up, till 10 years. So much of follow-up is required because they have got very high chances to come back again. Recurrence is very, very high. So this table, they gave a link in the guidelines, so I just put this table. No need to remember so much about it because it is not of use. So now the vulval Peyer's disease. Vulval Peyer's disease, it may be asymptomatic, or the patient can come with itching, burning, irritation. Usually there will be, it appears as red, so erythematous plaque with a white scaling, and it is called cake icing scaling. This is the key word here, because many of the time you will find question where they will describe the lesion as cake icing scaling. So now you got the clue for it. And with the Peyer's disease, we already know underlying malignancy may be there, of gynecology malignancy, urology malignancy, or colorectal tract malignancy. It can be there. So what is a treatment? Aim will be to clearly excise it. Aim will be to clearly excise it. Apart from this, imiquimod can be considered. Radiotherapy, photodynamic therapy can be done. In Peyer's disease, usually very, very high chance of recurrence again. So long-term follow-up would be required in vulval Peyer's disease. Okay, so that's all I had to say. Any one of you have got any question till now? Okay. Now, this is the survival rates. Again, these are from the website Cancer Research UK. So this is the 5-year survival rate. So stage 1 is like 80, stage 2 is 50, stage 4 is 40, stage 3 is 40, stage 4 they have not given in the they have not given in on the website, so I didn't put it here. Okay. Now, overall survival for 1 year, because recently this 1 year survival also started coming, it is 85%. Overall survival for 5 years will be 65%. I know the percentages are important to remember, but they want us to know that. Even part 2 and 3, both people required that. Apart from this, this guideline suggests about the melanoma 5-year survival. So melanoma 5-year survival is a 15%. Melanoma 5-year survival is a 15%. Okay, so that's all I had to say. Now there would be some question discussion. Any one of you have got any question can ask me, or we can proceed with the questions. Any query, people? Okay, so let's go to the question.
Ma'am, there is a question when we have the diagnosis of squamous cell carcinoma.
Mhm.
So why we have to rebiopsy then?
Rebiopsy? No, if the treatment is done and the pathological margin of histopathology comes positive, then only re-excision.
Ma'am, there is written like biopsy is done before the management when once there is a diagnosis of squamous cell carcinoma, vulval one. So the diagnosis is made on biopsy only or something else?
No, on the biopsy. See, after first they will do clinical examination, then they will consider doing biopsy. After biopsy, the diagnosis is made, then they will consider removing the
Yes.
lesion. On the removal of the lesion, the whole specimen will be sent for the histopathology. If the margins are free, then there would be no problem. But if the margins are positive, then they will consider re-excision.
Okay, ma'am. Thank you.
Okay, welcome. Okay, so a 75-year-old woman with a history of vulval itch and soreness from last year, worsened over last 10 months. On examination, the vulva appears to be thickened with the white plaques. Some areas are elevated, irregular surface contour, feel firm, tender to palpate. No obvious ulceration. What will be the next step?
Ma'am, A, refer to Gynecological Cancer Center.
Before that, you can. So if you see a
We
patient,
can take a punch biopsy also, we can take it out,
yes,
ma'am. Yes, we can
You
take
have to
biopsy
confirm
and
it.
we can send it.
Yes, you have to confirm the diagnosis first, so there should be biopsy. So this is the
Okay.
same thing that someone was asking. So see the take the history, do the examination, do incisional biopsy to confirm for the confirmation of diagnosis and find out the depth of invasion. If the depth of invasion less than 1 mm, then treatment. If depth of invasion is more than, oh sorry, once it is mm, then consideration for like inguinal lymph node imaging and then treatment. Okay.
Yes, ma'am.
So 75-year-old woman with a urgent referral to the 4-month history of vulval pain. She has 4 centimeter exophytic tumor replacing clitoris, extending to 15 mm of urethra in large lymph node in both groin. Groins are there. What will be the next step?
Ma'am, wedge biopsy of the lesion.
Yes.
Yes.
Again, the same thing. Confirm the diagnosis first.
Mm.
So, 75-year-old woman in Urogynec clinic with a pelvic prolapse, and um, uh, there is a history of intermittent steroid use. On examination, there is a lesion 1 centimeter, 1 into 1 centimeter, left interior aspect of labia majora. So, what will be the most appropriate action? Arrange excision biopsy under local anesthesia, prescribe local topical imiquimod, reassure the woman that condyloma are common here in postmenopausal, concentrate on the reason for referral for pelvic organ prolapse, refer to dedicated oncology vulval clinic, try a course of topical steroid, and review the lesion in 6 months.
It's 5, ma'am. Try a course of topical steroid and review the lesion because she was using the
4,
steroid
ma'am.
on and off.
4, ma'am. There is a warty lesion.
Refer to
So
dedicated
dedicated
gynecology.
gynae oncology.
Yes. Answer is refer to oncology and vulval clinic. Now this question will be done with the by the exclusion. With the first they are saying excisional biopsy that we can't do, so it will
Okay.
cannot be the answer. Prescribe topical imiquimod. So we are suspecting cancer because it is a warty lesion, and in postmenopausal women and warty lesion, these two are the clue for suspicion of cancer. So you will not ask them to apply imiquimod. Finish. This cannot be the answer. You can't reassure the woman for condyloma. So this could not be the reason. You try topical steroid and see lesion in 6 months. So you are suspecting cancer. She has already used intermittent, though. She has already used steroid. So again, giving steroid and calling after 6 months, this much older woman, it is not a reasonable choice. So answer will be this
Ma'am,
only.
I have a
Yes,
doubt in this question. A warty lesion or a basilar lesion is most common in premenopausal with HPV infection, right, ma'am?
yes,
Postmenopausal, they are more common, like sclerotic infections are more common in a postmenopausal
yes,
rather a premenopausal, right, ma'am?
yes.
But here it is, she is postmenopausal with warty lesion.
See, you are very right. Even when I was putting this question, I also had this kind of,
Yeah, correct,
why they
ma'am.
have brought up warty lesion. They should not have written it. But this is a question from the strategy, so I didn't change it also.
Okay, ma'am. Okay.
But if you change the warty lesion also, then also the answer will remain same because it's a postmenopausal woman, and with the already she has used a steroid, so she has to be referred.
Okay, ma'am.
Now, 77-year-old woman in the seen by the GP for routine call. She mentions that itching has been worse over a year. She has applied different creams by pharmacist. She also mentions that she has swelling like a 10 pin as coin. She referred to hospital and examination. There is a raised ulcer with rolled edges. So this is cancer, okay? A general examination, no notes. Biopsy is already taken. So now what pre-op arranged? So what will be the answer for pre-op?
D, ma'am, because initial investigations are D. FBS, serum biochemistry, chest X-ray, ECG.
Uh, yes, you are very right. It should be that only. But
Because no nodes are palpable, right, ma'am? So why we have to go for a CT?
yes, you are right.
But it's a long-standing one, no, ma'am. It's getting worse, her symptoms. So maybe we'll also do the CT pelvis to see the extension.
Uh, but the notes are not there. There are no notes.
It may be micrometastasis, doctor, because we need to know
Yeah,
if there is lymph
not
node, there is
everything is
also
picked up on clinical assessment.
yeah.
See, basically, this is a confusing question, but I put it. So this question is from Strategy, and they have put 4 as an answer. But I was not convinced with the answer number 4, so I put 5 as an answer. Because uh, this is from the again pre-op recommendations. So they say for imaging, because on the basis of imaging only they will decide where a sentinel node biopsy has to be considered or not. And they say that it has to be excluded by clinical examination and imaging. So imaging they have said, so it will be according to the new guideline, the answer should be CT, CT pelvis included. But I so but from previous guideline it was answer was D. So new guideline answer, because they are saying for the imaging, so it should be 5. So it is a confusing, but from new guideline it should be 5, and a strategy answer is 4. But I think the strategy has not updated. Okay, so I will put 5 only, but strategy answer is 4. Okay, you see a 60-year-old woman at Vulva Clinic. She initially presented 2 weeks ago with the soreness and irritation of vulva. On examination, there is a 4.5 centimeter lesion on left anterior vulva involving clitoris. Punch biopsy was taken. There is a squamous cell carcinoma. So, how would you counsel for lymph node management?
And one
Bilateral
I,
inguinofemoral, ma'am. First option. Why? Because it's involving clitoris.
Yes, central lesion and
Hmm.
more than 4 centimeter. So ideally, there should it will be bilateral lymphadenectomy should be recommended.
Yes, ma'am.
So 65-year-old woman with a soreness of vulva, there is a raised irregular erosive lesion 1 centimeter in diameter. What you will do next?
Incisional biopsy, ma'am.
Yes, incisional biopsy.
No biopsy.
Yes. So first you have to do biopsy for confirmation. 70-year-old woman with a 3.5 to 4.5 irregular fungating mass extending to clitoris. Biopsy has confirmed moderately differentiated squamous cell carcinoma with a depth of invasion 8 mm. So, what will be the plan?
B, ma'am. Radical
2,
wide
ma'am.
local excision. B.
Yes,
Bilateral groin lymphadenectomy.
yes, because it is a central lesion, so it is bilateral. 85-year-old woman with irregular lesion, left labia majora 1 into 1.5 centimeter. Punch biopsy shows it is a well differentiated squamous cell carcinoma, depth of invasion zero point 0.9. MRI shows no lymph nodes. So, what will be the appropriate management?
Radical wide local excision, ma'am, because it's less than 0.9 mm, less than 1 mm depth of
Yes.
invasion.
So it is a radical wide excision because it is less than 2 centimeter and less than 1 uh, no, yes.
Less than
So
1
it is
millimeter, ma'am.
less than 1
Invasion.
millimeter. So it will be like it will be excision only. This is the definition of radical excision from previous guideline. 77-year-old woman with irregular vulval lesion, left majora, with a past history of hypertension, COPD, atrial fibrillation. Lesion measure 3.5 to 4.5 centimeter. Rolled edges with irregular contour. Lesion involve left majora minora, at least 1 centimeter clear of urethra anus. No palpable lymph node. Biopsy confirms squamous cell carcinoma. Depth of invasion 4 mm. And MRI shows no lymph node.
Should be a palliative method, ma'am. Palliative chemoradiotherapy.
Palliative
Ma'am,
radiotherapy.
Primary
Rad-
chemoradiotherapy, ma'am.
Ma'am, radical vulvectomy and sentinel lymph node
ma'am,
biopsy.
radical valvectomy and bilateral groin lymphadenectomy.
Radical vulvectomy and radical bilateral groin lymphadenectomy. This is the answer. Though she has got so much comorbidities, but okay. So now you read 80-year-old woman. Now you read it from here. So histology shows vulval carcinoma, left labia majora with depth of invasion less than 1 mm and a thickness of measures less than 2 centimeter. No lymph nodes. After discussion with the team, she goes left-sided vulvectomy and left node dissection. Final histopathology reports come with a 2 centimeter tumor with a clear margin. 1 out of 5 nodes are sampled for uh, like a groin containing metastatic tumor. What is the stage? So what is the stage?
It might be a 3A, 3B, ma'am. They didn't mention
3B.
about the lymph node size. If more than 5 mm, be 3B.
Yes. So involvement of any lymph node. Uh, so it will be like 3. So new and old staging will be answer 3A, but in new staging, any lymph node less than 5 mm invasion. And 3B will be more than 5 mm invasion, and 3C will be extracapsular spread. So same thing, 3A lymph node metastasis less than equal to 5 mm, 3B more than 5, and 3C regional spread, extracapsular spread. So 55-year-old woman with a lesion on left labial lesion. Biopsy shows squamous cell carcinoma less than 1 mm, more than less than 1 mm stromal invasion. So treatment is done. Non-clitoral lymphatic drainage. First drain where?
Superficial inguinal nodes, ma'am.
Superficial inguinal lymph node.
Yes, ma'am.
So this is a good picture about the vulval lymphatics. So and this important to know about the vulval lymphatics basic from our undergraduate days. So vulval lymphatics may cross in midline, and pattern of lymphatic metastasis from midline tumors is different from the lateral tumors. Okay, lateral tumor and midline tumor, central tumor, I have already explained you. So vulva will drain first into the superficial inguinal lymph node, then to the deep inguinal lymph node, deep femoral lymph nodes, and then they will finally go to the external ilia group of lymph nodes. Deep femoral lymph node, as we already know, they lie medial to the femoral vein in the femoral canal, and most superficial will be the clocoid node that we read in first year of MBBS. Now, clitoris and perineum, that means the center of the vulva, they have bilateral flow. So, unlike rest of the vulva, lymphatics will from the clitoral region may pass to the superficial inguinal lymph node, or they may pass deep into the deep femoral lymph node. If the tumor lies in the mid line, and deep femoral lymph node may already be involved, and the super without involving superficial inguinal lymph node. With the lateral tumors, deep inguinal lymph nodes will be involved. It is very unlikely that deep will be involved first rather than superficial inguinal. Okay, lateral lesion it is not there, but central lesion it could be there. So there is a crossing of the lymphatics. Okay, because of uh, because of that, for the central part of it, if you find any lesion in the central part, so we have to consider for the bilateral uh, lymph node treatment. Okay, and for the lateral tumor we are doing unilateral or ipsilateral. So now this will be very easy now. So initially they spread to
Inguinal nodes, ma'am. Inguinal
yes,
nodes it is.
nothing to be said. So 70 years old woman with the vulval itch and bleeding, on examination suspicious lesion, find out and the biopsy is done. Lesion confirmed squamous cell carcinoma with a depth of invasion less than 1 mm. So if less than 1 mm, then how much is the lymph node involvement?
Less
Less
than
Less
than
than
1%,
1%.
ma'am.
Yes, less than 1%. Now, which type of vulval VIN is associated with greatest progression to squamous cell carcinoma?
D, ma'am. HPV
differentiate
16.
No, I just explained.
differentiated type.
Differentiated.
Differentiated,
Yes, yes, ma'am. Yes, sorry.
differentiated, that is DVIN.
Yes, yes, ma'am. Yes, ma'am.
Okay, now 90-year-old woman with vulval cancer imaging uh, shows metastasis to both pelvic lymph nodes and inguinofemoral. What is the stage?
Any lymph node, it is
It's
3A, ma'am.
4A, ma'am.
4A
4A, ma'am.
because of pelvic nodes.
Hmm.
4A. Think again.
3B, ma'am.
D.
Yes. 4B.
4B.
Pelvic lymph node, these are like
Yes, ma'am.
these are internal lymph nodes, internal iliac, all these type of obturator, these are the pelvic lymph nodes. So
Yes,
it
ma'am.
is distant, distant spread. This is a good question, to scratch the head. So it is distance spread. Okay, they wrote pelvic lymph node here. Okay,
Yeah,
so it
yes,
is
ma'am.
very clear. They wrote pelvic lymph node. So it is 4B only.
Okay.
So 40-year-old woman with a severe pruritus, vulvoscopy shows acetowhite area, and it is usual type of VIN. She can be treated with what?
Should be wide localization.
Yes, wide localization.
Hmm.
That is a treatment of choice. Now this is again the summary of DVN and UVN. Okay. Now 70-year-old woman with rapid access clinic with the complaints of vulval itching and soreness. Vulval examination shows erythematous lesion with excoriation lignification. Vulval biopsy shows large pleomorphic cells with a prominent nucleus located under the portion of epidermis. Some occasional signet cells are seen. The cells are positive for all this immunohistochemistry. Doctor recommends vulval excision. So, what is the diagnosis?
It's Paget's disease, ma'am.
Pages.
Yes, signet cell happens in Paget
Hmm.
disease
Hmm.
only. So, extra memory Paget disease, and this is the complete summary for all vulval lesions. 74-year-old woman present with a vulval soreness. Examination shows 2 centimeter lesion on right labia from midline, 2 centimeter away from midline. Biopsy shows squamous cell carcinoma with a depth of division less than 1 mm. MRI shows no abnormality. Her case is disposed in MDT. What should be done?
E,
Wide
ma'am,
local,
wide local excision with groin lymphadenectomy on the same side.
Wide local excision.
wide local.
Why?
D, ma'am. Wide local excision.
Wide local
D.
excision.
Yes, because less than it is less than
1
4
mm.
and stromal invasion less than 1. So
This
it
is
is
one.
1A disease, stage 1A. So wild local excision is the answer. Now, this is from the new guideline again. Depth of invasion less than 1 mm. So wide local excision with photo and diagram indicating biopsy site or like no sentinel lymph node biopsy.
Yes, ma'am.
Okay, so 53-year-old woman presented to GP with itching and soreness. An examination 1.5 centimeter lesion on the right labia. Histology shows squamous cell carcinoma. Stromal invasion less than 1. What should be done?
Wide local excision, ma'am, with
With 1
1
centimeter
centimeter
margin.
1
margin.
centimeter margin.
Oh,
Yes.
Oh,
Oh.
So, 76-year-old woman with vulval itch bleeding suffers from dementia and treated for vulval dystrophy. On examination, 4 centimeter mass fixed to bone on labia and palpable nodes on right side. So, what should be the answer?
it's 4
it should be CCRT, radiotherapy.
radiotherapy with this
Way
one,
of
ma'am.
radio.
There is H, 4A stage.
Hmm. Stage is 4A. Answer is preoperative radiotherapy because it is too vast for any kind of surgery. In stage 4, there is they don't recommend surgery. 69-year-old with a vulval soreness, 15 mm lesion, right labia minora close to fourchette. Distance from the edge of the lesion and midline is about 1.5 centimeter. No node. What is the appropriate action?
Wide local excision with ipsilateral groin node dissection, ma'am. J.
Bilateral sentinel node.
Oh, ma'am.
Oh,
Yes, ma'am. Ma'am, it is a
uh,
lateral. It is
Bilateral
one.
sentinel groin node dissection, ma'am. Central.
like
Central.
less
Ma'am, it
than
is
1.
position, 1 centimeter away from the more than 1 centimeter, and size is
Okay.
also not.
Depth of invasion they have given or not?
15 mm they have given, ma'am, on the right labia close to the fourchette.
That is the size of the lesion, ma'am, not the depth of invasion.
The distance from the ejaculation and the midline is about 1.4
So it is less
wide
than 2
local
centimeter
excision
with
at
that.
the O, ma'am.
Yes. So it will be O.
Mm.
Yes, it will be O. But when I wrote the answer, I thought of like stromal invasion, 15. So I changed. So it will be this only. Okay, so 56-year-old woman with a history of itch. On examination, dry scaly lesion, biopsy shows vulval thinning and lichen sclerosis. What will be the appropriate action?
Steroid cream L first.
Steroid.
Yes. Now, a 60-year-old woman with 3 itching and soreness. She was examined to found a lesion on the left vulva. Tissue is taken with the interface between normal and abnormal. That is enough for pathology to see. So, what is the answer?
Incisional biopsy, ma'am.
Yes, incisional biopsy is the answer. So this is the definition of incisional biopsy they have given.
Yes, ma'am.
So now for 74-year-old woman with a small area on right labia majora, not associated, not irritating, well circumscribed lesion 1 into 1 centimeter with VIN with low suspicion of invasive disease, no palpable lymph node, lesion is removed. It is malignant, but the tissue removed does not provide tumor-free zone. So what to be done?
Re-excision, no?
Yes. The book answer here it is a radical excision, but according to the new guideline, it should be de-excision. Someone was asking this question. Now the things would be clear. 70-year-old woman with a lesion on vulva less than 2 centimeter. Lesion is separate on the lateral side. No palpable nodes. Biopsy is taken. Stromal invasion less than 1.
N, ma'am, wide excision and
Wide local excision.
Yes, wide excision. So now 82-year-old woman with recurrent abscess and it is Bartholin gland carcinoma.
radical vulvectomy, ma'am.
Wide excision with bilateral node dissection.
Wide excision with a bilateral node dissection because it is a central tumor.
Hmm.
So patient with malignant melanoma, 90-year-old, no enlarged node, lesion is confined to labia majora. Melanoma is excision only.
Yes.
Okay.
So surgery is performed in 79-year-old. Histology removed lesion shows squamous cell carcinoma, tumor-free margin of 10 mm, depth of invasion 6. Of 10 nodes involved, one shows microscopic disease positive. So what you will do?
Bilateral lymph node dissection, ma'am.
No.
Radiotherapy.
Mm, yes.
Adjuvant radiotherapy.
Radiotherapy. Yes, ma'am.
Okay, that's all, people. Thank you for joining. If you have got any question, you can ask.
Thank you, ma'am.
Thank you, ma'am. Thank you.
Thank you. Thank you so much, ma'am.
Bye. All the best.
Thank you, ma'am.
Thank you, ma'am.
Bye.
Thank you, ma'am.